So we have started our robotic program at HCG Cancer Center, Ahmedabad, May 2016, and you guys have mentored us in some of our early cases. And since then, as we gathered our experience, I thought that let's start sharing it as well. We started with proper selection of the cases, and then as we continued to have the volumes, at one point of time, we felt this moment of wow, that the patient who recovered and the patient felt good, I felt good, my team felt good, that, oh, this is really making a difference in our patient's outcome. And so then we thought that, what is this? I'm just, you guys may not agree with my definition of my listing of the high-risk patients that I have put in, because you guys are much more experienced than me, but this is what I felt. We had a 91-year-old woman who consulted a GI surgeon for her problem of the prolapse of rectum. This is the picture, and when she was evaluated for the same, they found out that she had a rectosigmoid malignancy along with this. The son came to me and he said that I want you to fix the problem of the prolapse of rectum. We would be okay if you don't do anything with her malignancy. I said, I'm an oncosurgeon, and I know only to fix the rectosigmoid, and I don't know what to do with the prolapse. But from my days of general surgery, I would say that if I fix up the problem of rectosigmoid cancer, probably the prolapse would also be fixed. So ultimately, they agreed, and we had our team evaluated. All patients would be evaluated by the critical care specialist and cardiologist as our preoperative workup. We decided to go ahead with anterior resection on her, and she recovered well postoperatively and discharged on 8th post-op day without stoma. I counseled the patient that no matter what, I'm not going to divert her, because if I divert her, do ileostomy, her quality of life would be ruined. So we took that challenge and did not do any diversion. And then we promised another thing also, that this would be the only visit that she is going to make to the hospital, because you understand, 91, fragile lady. And we promised to manage her at home, and our staff managed her at home. And this is what felt us good, that yes, this kind of technology is helping our patient. Then we had another patient, 66-year-old female, complained of dysphagia, and she was suffering from the polio since the age 3, so crippled, always with the crutches. And this is what you would see, that couple of other things. This is the type of spine that she had, and she had the entire stomach in her chest. So we had this couple of additional comorbidities that we were facing. This was a case of adenocarcinoma, and we still went ahead and asked her to have 2 cycles of FLOT regime that we used nowadays, and was treated at Jamnagar by the medical oncologist. After having done that well, we did her robotic Ivor Lewis operation, and she was discharged on the 7th post-op day. So once again, this is what we felt, that in my old days of doing open surgery of laparotomy and thoracotomy, she would not have sustained this, and she really did well. Very simple case again, a 68-year-old female with abdominal pain and had 2 lesions, a GIST as well as 1 ovarian benign tumor, and we did surgery single docking and did resected both. We discharged her on the second post-op day. And I'm sure this is also an experience of all of you that when we are dealing with rectal malignancy with synchronous liver metastasis, we can deal with them multi-quadrant access with our systems. So we had this Bangladeshi guy who had come with mid-rectal malignancy. Since he was coming from afar, we do have practice of short course of radiation in some of the highly selected cases. So we did give him short course of radiation and did a surgery just 1 week after the completion of radiation. And we did LAR with ileostomy and liver resection at the same time and discharged him on the 5th post-operative day. This is the pre and post result. My experience, so at our center, I do from esophagus to the colorectal, all the surgeries. We don't have yet experience with HPB in robotic surgery. So esophagus, we have 2 teams. One guy does the thoracic part, I do abdominal part. So this is our experience, mainly the colorectal work and esophagus, both that we have. Now, out of 138, 36, I would I have qualified them as high-risk group. One is medical high-risk and the surgical high-risk group, just for the matter of simplifying our observations. So 20 patients ASA grade 3 and 5 patients were more than 80 years of age, 3 BMI grade 2. And surgical high-risk patients, 3 patients had second pelvic cancer. One lady had been treated for cancer of the cervix about 6 years back, surgery and post-op radiation. And another 2 guys, one guy had undergone anterior resection in just a couple of months, had local recurrence, anastomotic local recurrence, came to a 77-year-old guy. We decided that, yes, we can still go ahead and do the robotic surgery. And another guy had undergone anterior resection and once again a rectal malignancy. Then, of course, intersphincteric axial coloanal and obstructed left colon, obstructed also. We had 2 more than, Clavian Dindo grade 3 complications. One was harmonic ureteric injury in a BMI 2 grade 2 patients. We realized immediately then and did treated, and he did well. One patient had pelvic sepsis. After he was discharged, was brought back again on about 6th, 7th day, and again managed by our team in a minimally invasive way. We had no respiratory complications, and that's what I feel that, it is very encouraging that all the high-risk patients, and they breathe so well, and that was definitely an advantage, and no mortality in all of these patients. I think this is a very small experience that I have tried to share, and I am now open to share the experience of all you learned guys and any question that you have. Thank you.